I'm going to introduce myself again. I realize now just how much better it is with the microphone. My name is Christian Klaus. I'm the spatial analyst at the North Carolina Central Cancer Registry. My talk today is on clarify. Yeah, do you know how to?
Just, I guess it's not a move. So we don't have to lean down. There we go.
There we go. Thank you.
Okay.
My talk today is clarifying uncertainty in residential geolocation of cancer incidence data. I have some disclaimers. I'm summarizing several papers into a 20-minute talk, and so I'm skipping quite a bit, just hitting the main points. The topic I'm discussing on is, we're still publishing on it. There's more to come, and right now we're just looking for input from the GIS and public health communities. I'd like to acknowledge the work of the county data stewards of address points and parcels who've been working tirelessly, dedicated throughout all these many years in North Carolina, as well as the folks at North Carolina's Center for Geographic Information and Analysis, CGIA, who have centralized and standardized those data sets. Without their contributions, I wouldn't be able to present on this work because I wouldn't be able to do this work. So it wouldn't be possible without them. And I also want to thank the Centers for Disease Control for continuing to fund us for our work on behalf of the citizens of North Carolina. So today I'm covering an overview of the cancer surveillance data stream, sources of uncertainty in cancer incidence rates, epidemiologic framework of person, time, place, and events. I'm going to talk a little bit about residential geolocation, which we commonly refer to as geocoding, and then how uncertainty stems from that, and then finally discuss residential geolocation discriminant power, otherwise known as RGDP because it's easier to say. So cancer data is different from other kinds of diseases and vital records like birth and death because cancer rates have an impact on citizens' sense of well-being and property values. And because of that, there's more of an infrastructure to support cancer surveillance, a small army of tumor registrars who are spread out in hospitals across the state, across the country. We also use edits and metadata, uncertainty metadata codes that you don't, for example, need with birth and death data. Our current geocoding uncertainty metadata is descriptive. You're going to see it later in the presentation. It's geared towards publication of county level rates. But there's been a change in the last few years where states are starting to publish rates at sub-county scales, particularly census tract. And as you move down, the scales become more local, the requirements for managing, let's just say expectations, citizen expectations about uncertainty in data increase. And so that's an issue. And so we have an incentive as the central registries across the country, we get together every so often, we talk about this. We have an incentive to supplement our current descriptive geocoding uncertainty metrics with quantified metadata, so the two of them together. All right, this is a very, very simplified depiction of data stewards in the cancer surveillance data stream. It's over on the left is where that's upstream, and then over on the right, you can follow the arrow, is downstream. On the far left, you see the database entities of tumor and patient. Patient and tumor are database entities that effectively co-author their own attributes. To the right of them are the emergency dispatch address point and parcel stewards. We refer to them as statutory stewards because at least in some jurisdictions in the US, there are actual legal statutes that define their stewardship. In the middle of the data stream are medical facilities such as hospitals that They have staff who co-author demographic data on behalf of patients. And then in the far right is the State Central Cancer Registry, and it's like a lot of other organizations. We're geocoding data all the time, and we're using almost exclusively geocodes that were authored upstream. One more thing I want to say about the patients. We consider them to be conditionally privileged stewards of their financial and demographic data. If 95% of patients are good stewards of their data, that means 5% are less than good stewards, hence the term conditionally privileged. We have to double check a lot of cases for that reason. So the big difference between the upstream stewards and the downstream stewards, the upstream stewards of, for example, the address points, they can focus primarily on positional accuracy of their data. They don't have to worry about problems with the addresses because they control the address domain. In contrast, the downstream stewards have to worry about both problems. So to summarize the flowchart we just saw, in general, upstream certainty stems from data compliance, data governance. In contrast, the downstream certainty, it stems from those things, but it also stems from data acceptance criteria because we have to use record linkage to fill in gaps in the data that we receive. All right, so I want to talk a little bit about uncertainty in cancer incidence rates, and to make it easier, it's easier to break it down into the numerator and the denominator. And most of my colleagues, when they think of uncertainty in cancer incidence data, they think of the denominator because of Census 2020 disclosure avoidance. For those of you who are not familiar with it, it's a policy that the Department of Commerce basically told the census they had to do. They modify population estimates in order to prevent the risk of outside actors positively identifying individuals by linking to census data. And so that's just something they have to do. The cancer registry community nationwide is working in concert with NCI, the National Cancer Institute. They've contracted a vendor, Woods & Pool, to develop a separate customized population estimate that includes, for example, age cohorts at tract level for the whole country, and it will include the Census 2020 as an input, among others. This is still in development, and we're waiting for it. I want to emphasize there's nothing conceptual about disclosure avoidance that has yet to be clarified in either the literature or the census websites. Until a few years ago, when I started publishing with my co-authors, that wasn't necessarily true about uncertainty in the numerator. Some very basic things had not been clarified there. So talking about the numerator, it's best to be able to break it down into the epidemiologic axes of person, time, place, and event. So each of these axes has a certain amount of attributes that go with it. So person has about 30 attributes, place has about 50, time is date of diagnosis, it's got a couple. In comparison to all of those, tumor has between 600 and 700 attributes. So when we're trying to explain uncertainty in cancer incidence rates, a lot of times we're talking to people who are just encountering this for the first time. If you don't have a background in epidemiology, it would seem logical that tumor's got the majority of the attributes, so it would be contributing the majority of the uncertainty to the rates. But that doesn't reflect how the data are used. If there's any uncertainty in a record, a tumor attribute, I should say, such as primary site or histology, that record is discounted. It's not used in the rates. And so furthermore, data diagnosis, the percentage of records with uncertainty in date of diagnosis, that would be a 4 or a 6-digit date of diagnosis field when it should be 8-digit. That's less than 1% of cases. And the cases that have uncertainty in patient identity are even more marginal than that. What's not marginal is the percentage of cases that have uncertainty in patient address at diagnosis. That could be 10 to 15% of cases on a monthly basis, let's say. So for a given set of cases, we expect the majority of the uncertainty is going to come from place. Patient, resident address at diagnosis, and then any fields that are derived from it, such as geocode and tract. Okay, I want to talk a little bit about the level of success in geocoding we can expect to get on patient data. First, I have to explain that in this country, there are two federal agencies that fund the cancer registries. There's the National Cancer Institute that's been funding registries since the 70s. They fund about 10 or 15 states, and then the rest of the states are funded through the CDC. North Carolina is one of those that's funded through the CDC. Why this matters is because the registries that are funded through NCI get more funding on a per case basis to carry out their operations than the CDC funded registries. The NCI registries, funded registries, have been able to geocode 98% of their cases to street level. Street level is address point, parcel, or centerline. And then the remaining 2% are homeless patients and other patients that are difficult to track down. North Carolina has a rate of over 95% of our cases are geocoded at street level. That's primarily me, and I'm able to do this because of the work of the county address point stewards and parcel stewards and CGIA. As a matter of fact, 91% of our cases are geocoded to address points. So we're able to do this because we have, CGIA, and we have these county level stewards, and the majority of the other CDC funded states they don't have something like that, or they haven't historically. And so it's much more difficult to get to the level of 95% for them. Okay, here's our best metadata field right now. It's a descriptive metadata field. It starts, I know it might be a little difficult to read, but the top line describes address points, and then the second line is parcel centroids, and then as you move down, it gets progressively less precise. It's a descriptive metadata field. It's nominal ordinal categories, and as you can imagine, it's very inexpensive to assign. We don't want to replace this field. We need it. We use it in our edits, but we do recognize the need to supplement it with something quantified. Okay, so I want to talk very, very briefly about geocoding and uncertainty that stems from it. Geocoding is different from other forms of record linkage in that, well, I'll compare it to patient record linkage. With patient record linkage, there's two outcomes, failure and success. By contrast, residential geolocation, by the way, that's just a specific type of geocoding. With geocoding, there are degrees of success. This is because of record linkage substitution, in which degrees of geographic precision are incrementally exchanged for less geographically precise record linkage success in order to avoid record linkage failure. So an example of this, we try to match a patient address against an address point. If that fails, try the parcel centroid. If that fails, the centerline, and then failing that, the zip code centroid. Each of these steps generates progressively greater sets of address point candidates collectively known as candidates of equivalent likelihood, or CEL. If we only had a zip code in a patient record and we matched to a zip code centroid, that zip code area may contain 4,500 address points. Each of those address points is a candidate of equivalent likelihood of an unspecified but intended patient address. And so we can leverage the CEL. 1 over CEL is residential geolocation discriminant power. That's a handy metric that we can't release for a single case because it would jeopardize patient confidentiality, because an outside actor could use that to link and then positively identify our patient. So instead, we could only release summary RGDP, which is RGDP summed across a group of cases. So yeah, here's the formula for RGDP. As N is the number of cases. As CEL increases, then RGDP decreases. RGDP ranges from 0 to 1. Okay, there's two concepts here that are very easily confused, and so I want to just quickly go differentiate them. The first one is residential address discriminant power, otherwise known as RADP. This is a theoretical construct that assumes that every address in a list of addresses is unique in its combination of zip code and county, and furthermore that it's closed world in which all addresses that exist appear in a database, and so is perfectly discriminate. This gives us a foil to compare RGDP against. So RGDP quantifies the loss of RADP that is the result of the geocoding process, and in particular, record linkage substitution. Okay, we calculated RGDP on 5,800 cases that we got in 2022. There's the box and whisker plot on the left is of cases, and on the right is of address points. And they're both broken out into columns based on rural or urban county. So we can see in the box and whisker on the left that there's a lot of variation in RGDP in the rural counties. This is consistent with literature that's indicated that the prevalence of poor quality addresses and or PO box addresses in rural counties is much higher in medical data than it is in for the urban patients. So we're not surprised by this. The other finding is that there really is no variation between urban and rural in RGDP between the urban and rural counties. I also want to note that the RGDP for the address points represents an effective ceiling for the RGDP of the cases. The case RGDP can never be better than the address point RGDP. Here's a map of it. This is for our entire case file. And you can see that, yes, the cases in the rural counties have lower values of RGDP than in the urban counties. Okay, to summarize, right now in the central registry community, we're looking for a metric to supplement the descriptive metadata, and we still haven't been able to come to consensus on it. One of the things that we can do with the quantitative metadata easier is to categorize the uncertainty that's in our data that we have no way to resolve and get rid of. We can categorize it by stewardship. And the three stewards I'm most interested in are the central registry, the E911 stewards, and the patient/hospital. I say patient/hospital because when we get data in, we really can't tell if it was authored by the patient or the hospital staff. In so doing, we can demonstrate that we're not responsible for all of the uncertainty in the data. That would be a big win for us. Let's see. Yeah, so we have an incentive. Okay. There's something else about this metric that gets to the issue of how do we describe error in geocoding. A lot of people think of describing error in geocoding with two methods. The first one is with string similarity, otherwise known as match score. It generally, there's a range of 0 to 100, and you choose a threshold in there. Above the threshold, the addresses are batch matched. Below it, they're interactively matched. That's number one. Number two is assessment of positional accuracy. And there are many, many ways that this is done in the literature. A popular one is to compare a ground truth set of addresses with their geocoded equivalents, and then compare the orthophoto distance and direction. But you think about it, there's actually two more legs of a four-legged stool. The third one is the discriminant power. The discriminant power lets us delimit uncertainty within the domain of residents. And since a lot of us are geocoding as downstream stewards, all of our geocodes we're assigning are authored upstream, the bulk of our discretion really is just limited to leveraging the discriminant power of residential address. This is the only metric that corresponds to that. So it's giving us something that the other two don't give us. The fourth leg is identifying the extent of record linkage exhaustion. We've talked about that in our paper. I'm not going to go into it now. So very briefly, I want to discuss the difference between capture and estimation. We can capture uncertainty when the cardinality of address point to residence is 1-to-1. In that case, we can be neutral observers of uncertainty that's authored upstream. When cardinality is 1 to many, then we can't be neutral observers. We have to become co-authors of uncertainty. Given that, we have an incentive to maximize the number of cases for which we are neutral observers of uncertainty authored upstream. So future directions, we're challenged to assign CEL to our 1.5 million cases. This is an expense above and beyond what we're funded to do. And certainly, you could probably count on one hand the number of states that could pull this off. We're in the process of identifying the costs associated with this exercise. We're refining our methods. We're optimizing our code. For now, what we're doing is just clarifying the concept and attempting to forge consensus on it within the public health community. Thank you for your time and attention. Yes.
Are you using Python script to do all your processing, or how are you doing like the actual processing of all the data?
The fastest possible way is SQL.
Okay.
And that eliminated Python as a possibility.
Okay.
So yeah, it's all about performance.
So what software then are you?
Yeah, go ahead. I'm sorry. The geocoding is primarily with SQL. So we're using the Esri products for probabilistic. For deterministic, it's all SQL, which is deterministic geocoding, for those of us who are not familiar, is just going through and evaluating candidate pairs. So probabilistic will match hundreds to thousands to millions per hour, depending on CPU resources. It's cheap. Deterministic is a little bit more expensive. It's hundreds per hour. It's going through these candidate pairs. We want to get rid of the probabilistic and deterministic matches before we have to spend time on interactive, because that is the most expensive. It's our biggest bottleneck. Yes? Great question. How many points are we geocoding? We're getting between 5,000 and 12,000 new cases a month. And generally, it's been manageable. We get, I'd say, 300 or 400 that we have to interactively do a month. And they can be very time-consuming. But we also have this 1.5 million that we geocoded in the past, but as new, better data comes along, we have to re-geocode it again, because it will be greater precision and it will pass more edits. And so throughout the year, we're handling the new cases on a monthly basis, trying to get them done by the 25th of the month. Generally, we do, but not always. But then the delta, the stuff that was already geocoded, that's re-geocoded, we try to cram that in like a 4-week period before we submit our data to CDC in September. And it takes all of that time. Yes.
Have you seen, you may not be looking for this specifically, but have you seen patterns or changes in the incidence rates post-COVID?
Yes, my colleagues have looked at that, and we saw a reporting lags that turned out to be more than lags. They just were not getting cases because of COVID. And they know more about it than I do, but I'm just kind of summarizing it for you. Yes.
You talked briefly about the census fuzzy situation. Just to be clear, you're not addressing that, you're just acknowledging.
Yeah, I'm addressing the disclosure avoidance system and the fact that we as a registry, we don't have a solution for it, and so we have to work in lockstep with other states, and everybody else is working with NCI, and we're looking to them for a solution. In the meantime, we're projecting forward from 2010, which is not ideal because it's going to overstate the rates. But we don't want to branch out on our own and have our own solution. We want to do what everybody else is doing.
Yeah, we've run into the same problem. Just kind of made the decision that the census data, there's nothing we can do about it. I feel your pain.
Yeah, and that's another choice, is just to use it the way, and for those who are not, completely familiar with the disclosure avoidance, what they're doing is decreasing the cohorts in the urban areas, increasing them in the rural areas, and then they sum out to a correct total at the county level, is my understanding. The effect of that is to overstate rates in the rural areas and under in the urban areas. And so, so everybody's just waiting and watching the clock. Thanks, everyone.